I also want to introduce to you the lady who is, she and her husband has sponsored this for 10 years. Holly Smith. Well, I tried, she wouldn't. So I want to introduce you now to Adrian Windsor, who will start the program. Thank you for coming.
Thank you, and you've just been hearing from our CEO of the foundation, Jerry Koppel, and he is spearheading the capital drive to raise the foundation's share of the building of that lecture hall. And it's a huge undertaking, because originally the price was going to be about $8 million, and now it's close to 24. So he wasn't hired for that, and he's taken it on. And I just would like you to give him some applause. So he stole my thunder. I was going to introduce Polly and, and her daughter Jen. And so it's so great to have them here tonight, because I always say that it's been very special for me to be a part of Medicine in Our Backyard, because I was at that meeting when we cooked up this idea, and Mike and Polly have supported us ever since. So it's been ongoing, and I know it's a gift to the community, and I know our speaker tonight's going to be impressed by the intelligence of this audience and the penetrating questions she's going to receive, because normally our speakers are blown away. So we welcome all of you here. So as Jerry said, I'm Adrian Windsor. I'm a board member emeritus, and I've been a part of this group, I think, since 2012, so that's a long time. I also want to acknowledge Kunga, our program director. She greeted you when you came in the door, and Jane Merritt, who works with UCI Health, and together they bring us these wonderful speakers that we are able to enjoy. So just a quick bit about the foundation. Jerry said you saw the video before. We are a membership organization. How many of you are members? Good. If you're not, Kunga's right there. She's happy to take your membership, or you can go online and you can join. And there are benefits that come from being a member. In fact, if you're a new member, we have a summer solstice in June with a special speaker, and it's like a cocktail party, and you will be invited to come to that as a new member to get acquainted with our community. You're the first ones to hear about our witty lectures, our library live lectures. And it's just a nice thing to be a part of everything that we do, because we supplement the library with things that the city does not purchase for it. And we are pleased to be able to do that. So please consider becoming a member if you aren't, and if you are, we thank you. So just a few reminders. We'll end up with a Q&A. And so please save your questions until the end, and we'll come around with a microphone and give each of you an opportunity to ask your questions. If you haven't silenced your phones, do that, please, right now. I just silenced mine. And I am pleased to introduce tonight's speaker, Dr. Valery Vilchez. She is a fellowship-trained UCI Health surgeon who specializes in laparoscopic and robot-assisted surgical techniques to treat diseases of the colon and the rectum. These are parts of our body we don't really like to talk about, but they are so absolutely essential to our well-being. And so I think we have to have great gratitude for someone who is willing to assist us with the issues that we may have there. Her clinical and research interests include multidisciplinary approach to the treatment of recurrent and advanced colon and rectal cancers, complex inflammatory bowel disease conditions, pelvic floor disorders, and anorectal disease. Dr. Vilchez earned her medical degree from the University of Zulia Faculty of Medicine in Maracaibo, Venezuela. Good. She completed her residency in general surgery at the Cleveland Clinic in Ohio, followed by fellowship training in colon and rectal surgery at the UCI School of Medicine. She's going to tell us what's new in the treatment of colon cancer. So we're very happy to have you with us tonight.
Well, hi everyone. First of all, I'm gonna do a couple of things. Whoever can come a little bit closer to me, great. You can move a little bit closer. I don't bite anyone. This is why I do. I have a couple of things. First, I'm not a member of the foundation, so I'm gonna talk to Conga when I'm done here because I live close by and I felt a little bit ashamed of myself with not being part of the foundation, but busy in other things. I'm really honored and grateful for the invitation and being here to talk about this important topic. March is a special month for me because it's called Rectal Awareness Month, and that's what I'm wearing blue under my red jacket because I think the best approach to cancer care is what we're doing today. Having this connection in between the community and the physicians that treat the disease is really important because you are experiencing the symptoms that we can actually detect. And there is a lot. We had a conversation with some, Megan was there at that point. We had some conversations with our patients at UCI last week, and I was mentioning something really important. Cancer care is also about breaking the stigma because people don't want to talk about it. We feel defeated, like in the movies of a cancer diagnosis is something that we cannot, treat or we cannot cure, and that's not correct. But it's a lot of misconception. And in the world that we live right now, in the world of the internet and Google and all of our AI opportunities and everything, is a great word to communicate and kind of like, especially after COVID and everything that has happened in our world, it's a great word to communicate and kind of expand our knowledge. But also there is a lot of miscommunication and there is a lot of misinformation. So having this connection with the community is really important to us as physicians. And I feel really privileged, but I also want to extend my gratitude to you all that you're taking time from your day life of your spring break, time with your family to commit yourself and come here and self-educate a little bit more and perhaps, hire, and fire me with those questions that you have at the end. Feel free to ask me any questions. The second thing that I always mention is, it's funny that you mentioned this, I took this route of doing colon and rectal surgery, and my mom and my dad, they're both teachers in the university in humanities, nothing in science, and I'm the youngest of 3 girls. And they were so proud of me being a physician, then becoming a surgeon. And one day I talked to my dad and my mom and said, I'm gonna do colon and rectal surgery. My dad looked at my mom and said, what did I do wrong? Like, why did she actually pick this? I'm on everything. You could have done plastic surgery or, anything else, And I say, this is one of the most wonderful subspecialties that they are. I treat patients that are from really kid or maybe just early, teenagers years to elderly. Female and males, I treat benign and malignant conditions such as colon cancer and rectal cancer, which I'm gonna spend a little more time talking about today. And I have a lot to be grateful every single day of my life because I help people to have more quality of life or extend their life. And that is the most important thing, time. I'm gonna kind of go a little bit more towards the surgical management, which is what I do. I'm gonna touch some things that we do. In cancer care, we always talk about multidisciplinary care, and that is gonna come as a recurring theme in my slides and what I'm talking, okay? You can definitely start writing down your questions, and I will try to just speak slowly, but if at any point you need me to just repeat something down the line, just speak up. I'm happy to just do that. And let me just try this and see. I have an introduction already. I was born and raised in Venezuela. I did medical school in Venezuela, and I came as a foreign student and work my kind of like life and journey in the United States over the last 14 years. And I ended up being really lucky. After doing a couple of years of research, ended up in Cleveland Clinic in Ohio, and then I trained. My last year of training here at UCI, and as I mentioned to my partners, they were crazy enough, and I was just, in love enough that we matched together, and I stayed with them. And now I'm part of what we are a team currently of 5 colorectal surgeons within UCI Health system, hopefully expanding soon. But we work in multidisciplinary care with not only other surgeons, but also gastroenterologists, oncologists, radiation, both, and medical oncologists, and the rest of the multidisciplinary care system that actually brings cancer care as a standard of care. But in my disclosures, I always say I'm a well-trained plumber, because that's what we do every single day of my life. But actually really well-trained after 15 years or more of training, right? But, it's funny because there is a lot of stigma. There's a lot of stigma currently even of how to do cancer surveillance or how to do a diagnosis. And people don't want to do a colonoscopy because a lot of things, right? They don't want to do a colonoscopy because what's happening with the prep, how much time I have to take off. I mean, what are all these, these all nuisances that I have to just go through to get my care. And the majority of you, or some of you, I'm hoping some of you, because I can see some gray hairs here and there, have done colonoscopies already in your life. And it's not the easiest of the procedures or the preparation. And I think it's important if we talk to our, care members, and the care team members about, what are the best strategies that we have, because each patient is individual, and we have new preparations, new type of preparations that we can use that are easily and more accessible to patients that might not tolerate the old school, 4 or 8 gallons of Golightly as we used to do. I will start with something really important. Colon cancer, rectal cancers is beatable. We can treat this, and I think it's not that you get a cancer diagnosis, and I actually saw 4 patients today with this diagnosis, and I have the same conversation of in different individualized ways, but definitely my first thing is, we are here as a team to help you through this journey. And it's a journey, and it might take for some people a year or more, for some people more than that. For some people it's a really short, just a surgery and then surveillance after that. But the reality is it's a journey that you have to get a specialized team to help you through it. In the US, this is really important, right? Why are we talking about colon cancer? Why are we making even a month out of this for awareness? Is basically a second most common cause of cancer-related death. And, while the incidence and the mortality is kind of decreasing in general, we have seen, and I'm gonna just quote Jerry when he said, some of you guys have gone through this, but unfortunately we're seeing more and more what we call early onset colon and rectal cancer, meaning people that we used to say, well, it was kind of like a disease of elderly or older people. Now we don't talk about that, I'm gonna put an example. Today I saw 4 patients, 3 of them were younger than 40 years old with newly diagnosed colon or rectal cancer. So all of you have kind of impressed, because this can happen to any of us. So what can we do, right? Or what can we not do? There's a couple of things I always think. Screening is key, and I think we have to consider some high-risk factors, such as, you have a family history, someone in your family, you have polyps, or someone in your family has been diagnosed, and when were they diagnosed? But also, some other risk factors that are coming a little bit more into perspective. People that have symptoms really early, like people that are bleeding or having just significant, problems. We don't think anymore as it's just hemorrhoids. We just pay attention to those details, right? And that means that it might just get a screen or kind of diagnosis earlier, because we pull for a colonoscopy early these days, or we pull for other testing that might help us to just get into the diagnosis. And I think that is just really important to consider. The other point is, anyone that does not have any high-risk factors or any family history, 45 is a new cutoff, It's no longer 50, it used to be the case, and we modified that. And I always make fun, but I tell my trainees, we have, medical students, residents, and fellows in the UC system that they rotate through us. And I say, when another one of my hairs just become gray, it's going to be 40. That's the reality, because we're seeing this, kind of, entire move towards, what the incidence is, and we're seeing more people really young with really bad conditions, right? The treatment is mainly guided in, first of all, stage. So when you have a cancer, no matter what it is, and this I'm talking about colon or rectal cancer, the first thing that we need to know is the cancer just localized in that place, or the cancer has gone through other places, okay? And then for that, we call the staging, in the sense of, we have to make sure that we kind of check all those places. Colon or rectal cancer likes to go to 2 main places outside of the main area, the liver and the lungs, which is why any that has been diagnosed from colon or rectal cancer usually gets a pan scan with a CAT scan of the chest, abdomen, and pelvis to check on the livers and the lungs. And usually for the rectum itself, a dedicated MRI of the pelvis, which is a standard of care, plus minus EUS, but most likely an MRI of the pelvis because it tells me a little bit more of what's happening in the surrounding of the rectum itself. And that can kind of like give me and the rest of the team the sense of where are we dealing with and what can we do for it, okay? When we treat colon cancer, surgery and chemotherapy are kind of like the strategies that we use in the initiation. And the majority of the patients, especially if it's early stage, surgery might be curative, in terms of I take that segment of the colon, put you back together, and that might cure the cancer. In the treatment of rectal cancer, and I'm going to kind of divide in some moments of my slides, both of them, because they can change a little bit. In the treatment of rectal cancer, it is important to coordinate if there is a need or not, depending on the staging of radiation. So the three kind of like multimodalities comes into conjunction: surgery, chemotherapy, and radiation. I specifically say this because I think this is the perfect audience for. In the community, there are multiple centers that give care. Not all of them are kind of accredited to just treat cancer, okay? And some of them, national-wise, are not. So rectal cancer, for example, is something that we treat in multidisciplinary manner. That means that we have to have specialists such as me in the surgical side, but also in the oncology side, in the radiology side, in the pathology side, that they are used to treat cancer, and they are used to treat rectal cancer. I'm proud enough to say UCI Health is actually the only one in the Southern California area that we have accreditation based on the national rectal accreditation program. That means that we have all the subspecialties to treat rectal cancer, and of course we have also advanced programs and clinical trials for those patients that have advanced disease, both in colon and rectal. We also have, and I will touch a little bit into that later on, but we also have other subspecialties that are developing strategies to treat advanced disease in the liver and the lungs, such as hepatic artery infusion pump, and we have one of our hepatobiliary surgeons running that program in UCI. So in that sense, and this is why I really like this communication, is you have to know what that institution is going to provide you, because it's not easy to treat cancer, especially in an advanced stage. So I am one of those persons that when someone in the community, even a surgeon themselves, call me and say, I just find someone that has rectal cancer, I say, don't do anything, send it to us. Because it's better to just have, first of all, centralized care, but second of all, actually subspecialized care that is actually accredited to do what we have to do. Because things, as also, this is a great portion of our world right now, things change really quickly. And as such, we're seeing these changes in the incidence of colon and rectal cancer, but also the treatments and the way that we treat it change a lot. And that's why, you hear news all the time, you hear new strategies, you hear new manuscripts that are going out, because we're trying somehow to get, or try to beat this, or get ahead of it before it gets ahead of us. So as I mentioned before, multidisciplinary care in team, like tumor board discussion, is really key management for both advanced colon cancer and rectal cancer. What can we do? What can you do? And this is what I do, right? I'm here doing some advocacy. I'm just talking as a humble, 30-plus person that treats this and see this every single day of their life. But also, I come from a family that actually, my grandfather passed from colon cancer. One of my uncles really close to me passed from gastric cancer. Another one passed from pancreatic cancer. So I come from a family that actually just triggered that passion on me, because I know that this is something that affects all of us. And in my family, we were affected from any single point that you can see it. So I'm pretty sure that any of you, if I ask you, know someone, or unfortunately someone in your family or yourself have been, dealing with this condition. So this is important what we're doing. So increase what you're doing right now. Increase your community and your own knowledge about this, and awareness. Know what we're dealing with, know what the symptoms are, talk about it. It's funny, but I always call, my friends' parents and ask them, like, have you been having bleeding? And then my friends are like, why are you calling my parents? And I was like, you know what? Because I care about them, but I treat them. And sometimes I have found people that needs a colonoscopy just because of that, because I just talk about this and I discuss with them and I say, what are your high risk factors? Hey, how is your diet? How are you taking care of yourself? So the awareness is really important. What you're doing here, again, I am filled of gratitude of you taking your time to just come and listen to me, because that means that you are willing to just, become part of that community that is spread the word, right? Inquiring family history. So people that actually are really young and they present with some bleeding or they get diagnosed, I always tell them, okay, we need most likely genetic counseling because of your time, and your age at diagnosis, but also let's just talk about your family. Let's see what's happening, outside of your home, but what has happened before or what can happen to your siblings or significant others because of this condition. Again, it's key that you do your screening colonoscopy. And I don't do this all the time, but I might pass after this and just ask each of you guys your age. I'm just kidding, I'm not gonna ask that. But I will ask if you are 45 or older or you have any significant high risk factors, talk to your primary care physician. And if you don't have a primary care physician, get one. That's my first advice, because this is important. As long as we can actually diagnose these conditions early, we have better chance of beating it. So that's one thing that we always have to think. Never dismiss symptoms, right? It used to be the case of like rectal bleeding in a 19-year-old, in a 20-year-old, in a 30-year-old. It's just hemorrhoids, and we just let it off, And today I had a patient, he's 37, and he has been having rectal bleeding for a couple of years. And he was like, I never paid attention to it. I was just like, I thought it was something that I ate. This is what happens. And he was just recently diagnosed with rectal cancer. So it just got worse, and he got worried at some point and said, I need to pull the trigger. So don't dismiss this, Even if it happened once or twice, okay, you tell me, and you have, significant constipation or other problems, perhaps, but don't dismiss this and ask, just reach out to your PCP. Again, and if you don't have one, get one, honestly, someone that you can talk about this, because it's really important for as much as it is important to have a good diet or, have a good balance on exercise or have less stress in our life, it is really important that you have someone in the medical community that can hear what you're saying. And I know you will tell me, but not all the doctors are the same. And I agree with that. I also have had not the greatest experiences sometimes, and I get it 100%. Someone is laughing over there because they know that I'm real about this. But there is someone there in the community for you. And perhaps if you don't get along with one of them, you can get a second opinion from someone else that can just, give you a better, kind of like at least a better ear for your concerns. Talk to your physician. I think that was enough. So what do we do? So once I have someone that has symptoms, I have to do two main things. I have to evaluate, I mentioned before, the staging. I also have to just do a risk assessment of what are we dealing with and what conditions can make this worse or can help me, right? And, one of the things is just having a cancer-specific history, meaning I have to make sure that I know what symptoms do you have, what is your main problem at this point, what are your medical comorbidities that can make this problem worse or can just like prevent me to do some type of therapy, what is your family history, and of course do a physical examination, and in that sense, in my realm, in the surgery, I always think, is this person gonna survive a surgery if I need to do a surgery or not? And if not, how can I optimize? And that's why my risk assessment is more, We do some routine laboratory values when we know that you have cancer. We have to check on your hemoglobin levels and kind of like minimal things, just know where is your status, nutrition as well. We also do some specific laboratory values that can help us to kind of like take care of you or kind of surveil down the time. And in the realms of colorectal cancer, the CEA is one of those proteins or markers that goes in your blood that we get measured at the time of diagnosis, and then we continue to surveil because it helps us to know exactly how the tumor is behaving. So it works more as a prognostic of recurrence, meaning the cancer coming back or survival, and it's a reference value for us down the line. Some cancers, the majority of them actually, are sporadic. In medicine, sporadic means we didn't have a cause that comes from your family or your genetics that can explain this. But some people might have some other causes, especially genetic components or syndromes that could be associated with colorectal cancer. Some of you have heard from them, Lynch syndrome or FAP, familial adenomatosis polyposis. And some of them, but there are really less amount of the cancers that are surrounding that area. So usually it's about 3 or 5%, we can say, of the total of the cancers that happen because of some of these conditions. But in those particular sense, two things are important. One, it's important to diagnose them, and that's why the genetic counseling comes into perspective, especially for young people, because they could be associated to other type of cancer, other conditions that may need to be treated down the line. So it's important that we know and we kind of like diagnose them because first of all, the treatment might change a little bit, but also they can make you a little bit prone to have other complications or other problems that we might need to pay attention to. what do we do first? Of course, the colonoscopy is really important. First, we have to have a diagnosis. In a healthcare system that works based on what the insurance wants to work, and we all have been through that as well, right? We all have to have a paper that says you actually have cancer. So the first thing that people is going to tell you is we have to have a biopsy because we have to have some tissue sampling, that the pathologists take a look under the microscope and they say this is cancer and this is this type of cancer, because that will actually trigger that the rest of things can be done and can be covered by the insurance or Medicare or all the things that might just like be in the counterpart of what we have to deal with. There's two things that I always take into consideration. One, once we have a cancer diagnosis, we have to try to surveil if we can or check the entire colon. There is not uncommon that we can see what we call synchronous cancer, meaning synchronous cancer is there are two spots where cancer can be developing in the colon, for example, or in the rectum in the colon, and it could be onto 4 or 5% in stage 2 or 3 cancer. So that means that you can have a potential second area where cancer is growing, or perhaps not cancer, but synchronous adenomas or polyps that could lead to cancer down the line, and that could be up to 50% in some patients. So it's important to evaluate everything. Now, what happens with patients, it's not unlikely, it happens to me probably once every week or every couple of weeks that I have a patient that comes obstructed, meaning if this is the lumen of the colon or the rectum, the cancer is growing from inside. Again, I'm a well-trained plumber, right? This is a plumbing system. If you have something that is just blocking the area in a pipe, the rest of the pipe is going to pressure, is going to go up, up, up. And at some point in a pipe, it just start leaking. That's what happens in the colon. It just start leaking. And poop comes outside of the colon, goes to the belly, and you get really sick. We call that an obstructive tumor. And that is an emergency because that means that I have to try to prevent that the pipe leaks. And one of the things that we can do is basically take you to the operating room and perhaps minimize the complications, bring in a bag or stoma or osteomy, or you can hear all of those words is kind of like similar, but basically it's just diverting the feces going through that area where the tumor is in order for us to treat the tumor and then, potentially treat it at the same time or in a second stage depending on, how sick is the patient. So what happens is, those patients don't get a full colonoscopy because they are obstructed, so we cannot pass. If the poop cannot pass, you can't even try to pass a colonoscopy or, even a small scope. So those patients, it is okay if we treat the cancer and then we'll check for the cancer. But those are the only people that I actually say we're not going to do a full colonoscopy before we start everything, because that changed a little bit what we have to do. I talked a little bit about the staging before. Imaging is really key, especially because of, is the cancer just in one place or it has spread to other places. And we have a big system. We call it the TMEG system, but it's a national and international system that we know that basically stratifies the cancer based on the location in the place where it's growing, in the nodes or lymph nodes that are accumulations of cells that are around where the vessel that feed that area is, and outside. And we call it the TNM because it's tumor nodes metastasis. Kind of like a simple way we simplified of where you're staging. And then, of course, some people might hear that you actually get diagnosed of rectal cancer and then you get all this staging, you start some treatment, and then you have to re-stage. The importance of this is, as I mentioned before, we treat rectal cancer with multimodality. It's not only surgery or chemotherapy, or sometimes we also have to use radiation. And it's important to see what the response of the tumor was initially to just get you into the next stage. So those people might have a re-staging, kind of like repeating all this imaging before we actually commit to the next step in the care. And this is part of what I do in my daily life. When we talk about surgery in the colon, and in the rectum, it depends a lot in where is the location, and this pointer is not the greatest, but we try to just work through it. In the top portion, you can see some of this, the right side, I guess. You can see some of the cancers that can grow in the right side. It can starting from the top here, you can see on the top right, is a cancer that is growing around the cecum or the first portion of the colon, and those patients might have just the resection of that area. We call that a right side hemicolectomy. Some people can have, and basically the surgical treatment in terms of where I'm cutting depends on the vessel, what is feeding that area. So the colon is kind of like a big as we're seeing over here, it's a big loop that is going all around our body from the right side to the left side, connected to the rectum and then to the anus, okay? And it gets connected, it's the same as the large intestine. If you hear large intestine or colon, it's similar. The small intestine is component by 3 things. The terminal ileum is the last of those that is connected to the cecum. And depending on where it's located, I need to make sure as a surgeon that when I take that portion out of the colon, I take not only the colon itself, but I take the vessel that fits that area, because the notes that it could be the first training station where the cancer goes lives around that vessel. So I need to make sure. And that's why I changed a little bit of what portion of the colon I take. Sometimes we don't have to do a full colectomy. Just special cases might be the case when we take the entire colon. Usually it's just a segment of the colon depending on where it is. So if it's in the right side in the cecum, we might just do a right colectomy. But if it's a little bit higher where kind of like the colon curves to go around the liver, we might need an extended because I'm taking more of the vessels and so forth in the different locations. There is this point of when we think that the colon surgery might be curative, meaning that the cancer is just in the colon and hasn't spread to other places and I don't give you any therapy before, we consider surgery curative, and we do what we call the oncologic resection and shouldn't be delayed. I always, and we have this kind of like goal within our system, especially in colorectal, we're a really tight group. I'm the only female, so I have those boys, really tied up, all of them together. We see newly diagnosed cancer patients the same week. That's our goal, and we shouldn't delay care, surgical, for, in the next 2 or 3 weeks unless it's necessary because we're going to do another treatments, okay? I mean, the patient needs chemotherapy or need radiation or need other things and we need to discuss in multidisciplinary because we shouldn't delay care. At the time of the surgery, there's a couple of things that we do. One, I usually do minimal invasive surgery, as Adrian mentioned. I do laparoscopy, robotic mainly, and in some instances, patients have had other surgeries before. It's not appropriate or safe to do minimal invasive techniques, and you might do the old school open, cut down. But in general, we check 2 things. One, do we check that actually looking inside kind of matches what we saw in the CAT scans or in the imaging, and you don't have any possibility that the tumor has gone through other places. There is no peritoneal implants, meaning that there is some tumor cells that might gone outside of the colon. And if that is the case, then we might need to put a stop and see how much is the burden of the disease, and if we need to do the colectomy at the time, or we have the multidisciplinary kind of discussion about when is the next steps. In the setting of obstruction, we usually try to relieve the obstruction, as I mentioned before. Sometimes we can cut the primary tumor and give you a bag, or sometimes we have to give you a bag because the tumor has extended to other places that might require treatment before that. This is a little bit of technicalities, but as I mentioned before, the extent of the surgery is not only that portion of the colon. I need to make sure that I take the lymph nodes. The standard of care is 12 lymph nodes at least. Usually it's more than that because there is a lot of lymph nodes that get also inflamed or reactive to the process that is happening. The body is the best machine ever. This is why I became a physician and a surgeon, because I get to work in the body every single day of my life. It is the best thing. It's the best machine because we actually have all these signals. The problem is we as humans, we don't read them. And that is just the usual, right? All these signals of having a little bit of aches or pains or fever, all these things that tells me something is going on. It's just your body saying, it's like your computer crashing or your system, not working. That's exactly what happened in our body, right? So there's a couple of things that we have to make into consideration. I have to take that vessel that fits, that's what we call the lymphovascular kind of like this dissection. Basically, I'm taking that vessel that fits that area of the colon with the lymph nodes that are surrounding it. Usually people say, do I need to take something else? Well, since you're there, can you take my gallbladder out? Hey, since you're there, can you cut a little bit of my tummy tuck? And it's like, no, we don't do all this stuff. And by the way, you don't want me to be your plastic surgeon. I'm a great colorectal surgeon. That's why I become one. But reality is, we take in block resection, meaning we can take some pieces inside of the abdomen as long as they are actually just basically taken from the cancer. Let's say that it actually is nearby or live nearby. So some people, I might come in and the cancer is touching an ovary, I might need to take that ovary. Or the person or the female might have really high risk factors to have other complications down the line, and for risk reduction might be beneficial for them to take it. That's a possibility. That happens a lot with the gallbladder or organs that are around it. So yes, there is a possibility that we need to just resect all the things, depending on the stage where you are and what are we gonna do. The goal is to take the entire cancer out, and we can treat you, if it's out of the colon or the rectum, we can treat you after with chemotherapy. In really experienced hands, minimal invasive laparoscopy and robotic is safe. That's one of the things I always say, because people come and say, are you sure that robotics is safe compared to, and we have proved that the oncologic outcomes, meaning the outcomes from your cancer, recurrence, survival, in, any type of morbidity from it, is as safe as we do in an open all-school surgery, with the top of you have better recovery. That's a reality. You have less amount of incisions, your recovery time is less. The postoperative ileus, or when the bowel doesn't wake up super, well after surgery, is actually less compared to open surgery. The pain control is easier because you have less amount of incisions compared to a big open surgery. That being said, in cancer, I always tell my patients there is two things that we have to think over here: taking the cancer and doing it safely. If that means that I need to do an open surgery, is what is safe for you. And it's just a matter of that, okay? At that point, it's really important that we do the oncologic care itself. But definitely, this is one of the things that actually I put into perspective a lot, because in great experience and in a multidisciplinary team, this is possible. And I will tell you that in my team, at least, we have the numbers. I know, 90% of our patients or more are done actually laparoscopic and robotic for cancer, even for advanced disease, because we can even take different organs and other things minimally invasive. Some patients, might need, because they have advanced disease, let's say it's a lot of bulky areas around and nodes that are around, they might need chemotherapy before, with the goal of controlling the disease, or kind of like shrink things before we go to surgery. And that is a possibility. And then we consider that, the chemotherapy or systemic therapy before might be helpful for us. We can decrease kind of like that tumor burden before we go in. Some patients might require it as kind of like a breach, because they get, a perforation or other conditions that might tell me that the cancer is advanced before I plan a curative surgery. And always in the back of my mind, I told you about a synchronous disease, so people that might have two places where the cancer has grown, and we have to discuss, those that people need, different portions of their colon out, for example, or do we plan to do an entire colectomy depending on other things as well. There is two particular kind of like population that I talk a little bit more in, and it's basically a talk itself, but in patients with IBD, inflammatory bowel disease, and ulcerative colitis that have a little bit higher risk of colon and rectal cancer, a total colectomy might be something that we put into the play, meaning taking the entire colon out because of the risk reduction of it. And because when the presence of a cancer is already there in the setting of chronic inflammation of the colon, there could be other sites of cancer that we cannot see, or microscopic disease or invisible disease. And the other thought is patients that had some of the conditions, genetic conditions, as I mentioned before, that they might need because of risk reduction as well, to take the entire colon out. Some people are actually what I call polyps formers, so they just have polyps all the time. And some of you might get these colonoscopies every year or every 3 years because your gastroenterologist, your PCP tells you, oh, you're just like a polyp former. You keep polyp formers. Thankfully, nothing is cancer, but we need to keep catching on them. So there are people that have conditions that actually they can get cancer really early on in their life, because those polyps just kind of like reproduce really early on, and they can cause cancer early on. So those are conditions that I always take into consideration, which is important that I come back to my first slide, doing a physical and a history that is really appropriate for each individualized patient is important, because I know what risk are we taking into consideration, what are your other morbidities that can actually change my management. When expertise is available, I mentioned again, the minimal invasive approach is actually preferred, because all the things that I mentioned, the oncologic outcomes, meaning how much your survival or recurrence rates are going to be, and how much your morbidity or mortality can be from these. It's similar to open surgery, but also it just gets a better recovery and a better form down the line. Okay. There are some patients that you might tell me, hey, you know what, but they took a cancer on me via the endoscope. They actually went in with a colonoscopy and they removed this polyp that was cancerous. And there are some selective patients that we can do that we can do transanal excision or we can do endoscopy excision, and it has to be a really early on stage that we are sure that we're not leaving anything behind and that this has not spread to other places. So there is some role also from the endoscopic or the transanal excision. Rectal cancer is a different kind of beast in between the same, I guess, group of beasts and animals, And I mentioned something before, again, the repetition here is going to be key for me. Rectal cancer is something that we need to actually treat in a multidisciplinary team. And we at UCI Health, and the majority of places that are accredited, they do the same. We do this multidisciplinary tumor board discussion every Tuesday, actually, afternoon. My team, including ourselves as surgeons, the radiation oncologists, the medical oncologists, the pathologists, the radiologists, the surgical oncologists, we all sit together, now via Zoom, of course, because, all the post-COVID via Zoom situation, but we sit down and we discuss every single one of our rectal cancer patients or advanced colon cancer. So we all play into or take time to just hear our ideas, and this is how things develop, because sometimes I might say, I think this patient is a great candidate for this clinical trial, for example, because it's someone that might benefit of the outcomes that we have seen on these, and this is when we discuss these kind of things. So it's really important that if someone in your community, in your family, your significant others, yourself get diagnosed, get into a place where they have this opportunity, that they have people that actually specialize in each of those realms, that they can come together as a team and put their ideas together. There are some patients, as I mentioned before, with local excision, meaning taking that portion of the colon inside of the mucosa without needing to just take the entire rectum out. It's feasible depending on the staging. It has to be really selected patients that are early on in their stages and they don't have any risk factors that can potentially increase the probability of you having a recurrence of the cancer or having problems down the line. And there is a lot that has been ongoing online and in different centers here in the US and outside, and we do different strategies now. Some people get treated with chemo and radiation, and then we do what we call a watch and wait protocol. I have a little bit more of that after that. We basically take a really good look at you every 3 months or so to check if the cancer can come back. It's really selective patients again. It's just something that could potentially be done. But again, this is when the multidisciplinary team discussion is really important, because then we can actually know, is the patient compliant enough, and is this something that is feasible, or are we going to actually leave some cancer behind and we're just doing harm more than help? Usually when patients get diagnosed in stage 2 or 3 in rectal cancer, we recommend neoadjuvant therapy, meaning the patients go on chemotherapy and radiation before. There is a couple of caveats when we treat rectal cancer, and I divided the rectum in 3 portions in my mind. So patients have really high rectal cancer that kind of mimics what colon cancer is, and perhaps resection or basically surgical treatment will be the first thing to do. And I'm trying to just go into this area, but this is in the lower portion. This is what we call the rectum, which is connected to the sigmoid colon. It's an S-shaped type of the last portion of the colon, and then to the anus over here. There's a couple of things that has come into the equation of this, Patients should be taking, as long as we're taking the portion of the colon, as I mentioned before, I'm taking also the vessel, and I'm taking the vessel with the lymph nodes. Those lives in kind of like a fat that just keep everything surrounding in the colon. We call that the mesentery. The rectum has its own mesentery. We call it the mesorectum. It's just a similar thing. We're not that smart. We put things really specific for us to remember, right? And it has been proven that we have to take, this mesorectum along with the rectum if we're going to remove it, because the risk of recurrence in that area could be higher if we don't do it. And that is part of the surgical treatment. And that was actually one of the things that makes me a colorectal surgeon different from a general surgeon. I train specifically on this. I train specifically on working in the pelvis because it's a different kind of type of mentality and surgery. And especially for cancer care is really important, because this is what changes what your kind of outcomes are going to be from the cancer perspective. Is this cancer going to come back, and what is the probability of that cancer coming back or having problems? Every time that, again, I'm going back to, I'm a plumber, well-trained plumber. Every time that I take a portion out of your colon or your rectum, I leave 2 ends or 2 stumps of things that are supposed to be connected, that are not connected, we have to connect. In medicine, we call that an anastomosis. And as a pipe, this could be something really easy that heals really well. But When people have had radiation, for example, starting on the rectal cancer care, and they have radiation, the tissues kind of like get, as long as we kill the cancer, we also kind of like kill good cells. So the tissues doesn't get or doesn't heal so well. So you might hear some people that might have rectal cancer, got radiation and chemotherapy, and at the time of the surgery, they ended up with a small bag, temporary, or maybe after, even permanent, because the tissues didn't heal well. And that takes a little bit of into consideration, is that anastomosis or connection gonna heal well? And some people that might have a portion of their rectum out and then reconnected, they might need some time to heal to prevent that leak. The problem with leaks in cancer is not only related to the problem of the leak itself, but also for the recurrence of cancer could be higher in those patients as well. So that is things that we'll take into consideration is, we take into consideration where is the location of the cancer, has the cancer spread to other places, is it in a place that I can safely take it out, can I take it out completely, taking all the fat around it? In the case of the mesorectum, we call it TME because it's a total mesorectal excision, that's kind of like the medical term, and can I do the anastomosis well? Do I need to consider fecal diversion or not? All of these things are things that I'm thinking as a surgeon, but also we discuss as a multidisciplinary team. They're going to the point that I'm going to go again, minimally invasive techniques, robotic and laparoscopy. It's safe to do in rectal cancer as well, as similar to where we have, we have a study in colon cancer and rectal cancer as well. And I put all that time as well because that's what I do, but that's what we train. And, and that is the most important. Again, the outcomes are a little bit better in terms of, how your recovery is going to be, and the oncologic outcomes are similar. And I always like to put this slide when I talk about it. There's a lot of like medical terms over here and things, but look at this time frame, over the last 30, 35 years, in the treatment of cancer, in the treatment of rectal cancer and locally advanced rectal cancer, meaning cancer that has gone outside of the lumen of the rectum itself and is going around the pelvis of some organs around. We have gone through, back in the days, we just took everything out and we leave you with a permanent colostomy. We treat you with some radiation, chemotherapy, and then we go through these, segments of we figure it out what was the best thing for treating it in terms of like we have to do a total mesorectal excision, we can give you chemotherapy, we can give you radiation. There might be a chance, down the line that we start doing some trials of when to give each of them, and it depends on really individual cases. Sometimes we do upfront radiation, sometimes we do upfront chemotherapy. Do we do a short course or a long course? There is a lot of variations here, and it depends on the individualized care, up to, the new era where we're using neoadjuvant therapy and kind of what we call watch and wait to watch the patients, meaning that we treat you with chemo radiation and we might be able to spare doing a surgery in really selected cases. And I want to be really, in my words, really appropriate here, because everyone in cancer care needs to be individualized. So there might be some cases that this is not possible because of the cancer itself and how advanced it is, or because the patient doesn't qualify for those. But those are all the strategies that we have in our armamentarium as, we treat. Nothing is for free, especially in this country, right? We all know that. But the reality is, even when we do surgery, you can have some complications and some things. And some of you guys that have had patients or family members or in the community, someone that have had any of these surgeries, they might confront with some things, and things like simple, like, well, we give you some blood during the surgery, but it could be other things like we actually kind of change your style of your life, People that have removed part of the rectum serves as a reservoir, and I always make this comparison. Then I connect your colon with your rest of your rectum or, lower rectum, and it doesn't function the same. It's like me speaking in English. I can really communicate well, but you know that I have an accent. So I make my mistakes here and there. You let me go because I try to just save people. So you say, well, she's a physician, she's a surgeon. We can let it ride, right? But that's the same what happens with the colon. The colon was not made to make a reservoir. The colon has other functions. So when you ask them to do the job that is supposed to be done by the rectum, might not function perfectly. So patients that have had low anterior resection, which is a resection of a portion of the rectum and reconnect the colon with the rest of the rectum, they can have these kind of erratic bowel movements, more frequency, more urgency. And then these are things that I actually have to discuss with my patients, because I don't want to give you a quality of life. Yeah, we save you with the cancer, but you're going to be miserable the rest of your life. That's not the goal neither, right? We have to do something that is quality of life. So some people might say, well, I got a surgery for cancer, for rectal cancer, and I had to, had a bag. or a permanent stoma, and there is a lot of factors going in. Perhaps, your baseline, kind of function is not perfect, or perhaps we're just gonna give you a worsening function down the line, and having a bag might not be as detrimental as having to go to the bathroom 20 or 24 times, especially for patients. I have patients that they live as, they are drivers. I have a patient that is a truck driver that I have to do a rectal cancer operation, and he told me, I cannot be in the bathroom every half an hour, I cannot have these problems, right? This is my life. So you strategize a little bit. Again, not everything is for free. You can have some wound complications, you can have some other complications down the line that I don't even mention here, but hernias, other things that actually are quality of life. So I always mention this because the first kind of like discussions is you might not be a candidate because of this, or you might be a candidate because of this. So, and again, this also goes to as early as we can catch the cancer and the earliest that we can be aware of what's happening, it can prevent that we have to actually use the worst resources. There are some emergencies, like always, I wish they wouldn't, because in the cancer care, the emergency means that it could be a more advanced disease. But three things could happen in general, right? Some patients can present with obstruction, as I mentioned before, that pipe just get kind of like really backed up and the pressure just start to open up. Some patients can start bleeding acutely from the tumor itself through their anus, and they become really symptomatic or anemic, and they have problems, they faint, and these kind of situations. And some people that might have some perforations, right, where actually the obstruction causes that pressure goes out and poop start leaking from inside of the colon. The first thing that I always think is, what are the strategies that I have as a surgeon, as a treated, part of the healthcare team? One, we have to diagnose immediately if there is something that might complicate the care. Two, we try to think about this is not a simple perforation, but it's a cancer or oncologic related complication, so we can aim and tailor the treatment based on that. So we have to try to achieve as best as possible tumor control. And, we have to ensure that there is a time that your recovery that is short as needed, because you might need other therapies. So let's say that you come with a cancer that is obstructed and perforated. I know that this is an advanced cancer, you might need chemotherapy. So my salvage position might be, well, I will do a bag for you right now. We might not take the primary cancer out because you are sick. You're going to get you into chemotherapy. I will bring you back after. And this is important when you are actually in an institution that we know what we're doing. I have received multiple patients from outside in other community hospitals where they get the incorrect surgery at the time because they don't have the resources, and granted, they are doing the best that they can with the resources that they have. But this is the important while, first of all, awareness to pick up this on time before the complications happen is important. But second, when this is happening, go to a place that actually they have the resources to help you, okay? Some patients you might hear some people say, well, they put a stent on me. They kind of like, put like a big kind of like protected stent inside of my colon to kind of like, avoid that I got obstructed. I'm not a big fan of them except in selective cases. Patients that actually need some staging because I want to decrease that size of the pipe before I do surgery, and I do an stent in a short period of time to bring it to surgery, or perhaps for palliative reasons. Someone that cannot go surgery, cannot go anything else, and this is more to just give you quality of life. But be careful, because in some instances, especially when we start doing other therapies or so, the stents are dangerous to use kind of like down the line. Some patients might present with acute bleeding from the bottom just because of the cancer itself, and those patients might need some other things, including, of course, transfusion, and kind of stabilize them. And depending on where is the cancer located that is causing the problem, surgery might be upfront. Sometimes it might be other strategies. For example, radiation works really well to stop bleeding from rectal cancer itself. So sometimes we merge the strategies together. We talk a little bit more of this, but in the setting of perforation, it's really important two things, and I have a lot of patients that have presented with this and say, are you going to take the cancer out? And I will say, again, if it's safe to do it. Sometimes you're really sick that we have to control kind of like what's happening and the infection can drive to sepsis at the time. So control, kind of like do a clean or a washout of whatever it's perforated, and then just do a fecal diversion before where that area is to try to just temporize how much is actually getting on contamination. Sometimes we can take the primary tumor out if the contamination is not too bad. And that means perhaps I can connect you again, do an anastomosis, and not having to just do a fecal diversion on a bag, before where that connection is, or I might do it, depending on the cases again, just to appropriately have time for that connection or anastomosis to heal to prevent a leak, which might complicate things. In the setting of perforation or someone that comes with that type of complication, I do not recommend stenting. I do think that is just, more the problem. The stents migrate, have other problems and issues. So there is patients that, unfortunately, they actually recur, right? I mean, yes, you beat the cancer the first time and you come back and you are in cancer, in rectal cancer and colon cancer. I always say you become my friend at least for 5 years, and then we'll talk about it. If you like me, you can come and see me. If you don't like me, I'm okay with that. But in reality, we're really a little bit more aggressive in the first couple of years because we know the recurrence rates are a little bit higher the first couple of years, and after that, we start kind of like unleashing you gradually until the 5 years, But some people can have recurrence. And some people have a little bit more predisposition because the tumor is more aggressive, presented really advanced initially, or it was a little bit more hard to cure in general. It might need a couple more things, not only surgery or so forth. What happens with those, with those patients? Again, I started my slides and my conversation saying this is beatable. So the fact that you even have a recurrence is not, a death sentence. It's something that even in a specialized center, we can actually treat. And we can try to just give you, if not at least a curative intent, a better quality of life. Some people, first of all, the first thing that are going to come again to me is, okay, what do? We talk in multidisciplinary care. Sometimes it's me as doing a colonoscopy, or one of the gastroenterologists doing a colonoscopy that find a recurrence. Sometimes it's the radiologist that pick it up in one of the CAT scans. Sometimes it's the medical oncologist who pick it up. So it's important that we just circle back to the team and say, I think this patient is recurring because of this, and just get the appropriate, again, staging and seeing where is this recurrent happen. I mentioned before the colon cancer and rectal cancer goes to the liver and lungs outside of our kind of like area, but the majority of the recurrence actually happen around the area where the primary tumor used to be. We call that local recurrence, meaning in the same area. Again, we're not that smart. We put everything simple so we can understand. And this means about, depending on where you read and what type of, staging we're initially, but it could be up to like 8 or 10% of the patients can have some recurrence. And there are some risk factors that make it worse or can make you more prone to recur. We talk about those, kind of like more aggressive cancers, basically, or cancers that, they need a chemotherapy and the patient didn't want to give chemotherapy because they were afraid of it. They have positive margin, or they left some of the cancer behind, or they have risk factors from the tumor itself. There could be really asymptomatic, sometimes it's recurrence. Sometimes we just pick them up in a lab work, which is one of the things that we keep just doing blood work, and we keep doing scans, down the line of surveillance, because that gives me a little bit of more of quality in general, in a global way, to just see that it's not only from inside of in a colonoscopy or inside evaluation, but also outside. But sometimes people can come with symptoms, bleeding, abdominal pain, other things that could happen. And I always ask, significant weight changes or so that can just be kind of like those alarming symptoms that comes to my mind, especially when I'm treating a patient that had cancer in the past. And again, we go kind of like baseline. We make sure that if the recurrence is happening, where it's happening, if it's extending to other places, so we can treat appropriately, okay? And that means that we might probably do another rounds of imaging and other studies as necessary. When the tumor recurs basically in a place where it used to be or around where the connection used to be or so, sometimes salvage surgery will be the answer. Sometimes we can resect areas or redo surgery around that area to kind of take that out. Sometimes the tumor recurs there, but it's going in other places, and depending on where it's going and the burden of the disease, we might decide, do we need to use other things? You would probably have heard some things that we use, new kids in the block. They're not that new, but it kind of like we get more data as we go on colon and rectal cancer. We now hear a lot about what we call circulated tumor DNA, which basically are tumor cells that we can measure in your blood, and we have testing specifically for that, and that have served a lot to two things. Serves a lot post, kind of like when we diagnose you and we do the surgery and we stratify things, we can kind of follow that during time and serve as a surrogate of how the disease is progressing, but also can help us to decide a little bit chemotherapy is appropriate or not, or is worth it or not in some stages of the therapy. As at this point right now, in 2024 March, we don't have great data on this as screening purposes. So it's not, a screening tool yet. More to say. Maybe I can just be invited in, 3 or 4 years again, and we'll talk of different things of what is happening, But as of now, it serves more as a surrogate of what is the disease process and how the tumor behaves. What happened with people that have a stage 4, meaning metastatic cancer? And we have known someone like this, we have had someone like that in our family, it could be any of us, and this is just a reality. Again, let's put it back into perspective. It might be beatable. It might not be as easy as stage 1 surgery and you go to surveillance, or maybe stage 2 and 3 and having other things. We might have to work in multidisciplinary team again to decide what is the best strategy to treat you. Again, as you see, the recurrent theme of me is multidisciplinary discussion. Like I talk to my oncologists, my gastroenterologists, my radiologists, my co-surgeons every single day of my life because of this. Because it's important to hear what the others are seeing, but also what your experience is and what is the best strategy based on our studies and the trials of like what is the best strategy to treat each patient. It is important to distinguish two things, what is actually we can take with surgery or what needs to be actually treated upfront before surgery, if any, There are some places where, the tumor is growing in the colon again, for example, but it's growing outside, let's say just isolated one small metastasis in the liver. That could be treated maybe both sides surgically. Sometimes we use some other local regional therapies in the liver, and then we just treat surgically the colon. So it depends on where it's located and the amount of the kind of recurrence or the amount of, in this particular stage, or the amount of the disease itself in a stage 4 that we can just decide what is the best strategy that we can use. And some patients, we give them chemotherapy when there is advanced disease to kind of shrink things, to make them resectable so we can actually go after with surgery and take that, disease, either in the liver, in the lungs, or in the colon or the rectum itself. Again, the multidisciplinary team is important, but it's also go counterpart, as I was mentioned before, going to an institution where we have the strategies, And I'm proud to say, we are one of those centers of excellence where in UCI Health, we can provide those things. We have specialized teams, including a hepatobiliary team that runs an hepatic artery pump or infusion pump program, which means people that have metastatic disease to the liver from the colon and other diseases, and they might not be candidates for surgery. Perhaps it will be a route to just give chemotherapy just to the liver and can shrink things in anticipation to potentially other treatments, including surgery. So we are running this program within us. And that also, it's really important to know in the community, because I have heard some patients of mine tell me, my oncologist told me I have liver mets and I'm incurable, and that's it, end of the game. And that's not true sometimes, Sometimes it's just a matter of like, what is the strategies that we have that we can give you? Now, is the journey easy? It's not. But is it in real, like life easy? It's not. So the same is just cancer. It's I call it a marathon. I always just, every time that I meet my patients, I say, okay, you're here in the start line, and here is your, your good and your granola bar, and this is all the things that you're gonna need on the journey. This is the team that is gonna be coaching you and helping you. The majority of the work is gonna be you. Sometimes it requires time and multiple things to do, including, multiple kind of strategies of treatment, but we have possibilities. What happened with people cannot have resection, meaning the cancer cannot be taken out. And I have these kind of patients, and I think it's important that we talk about what are your goals in life. I have patients that I actually sit down with them and I say, what do you want to achieve? If you have this amount of months, which I don't know exactly how much it is because each individual patient is, but what are your goals? And some of them are really simple. It's like, I want to see my niece graduation in 3 months. Okay, we can make that with a good quality of life, that you can go there and you don't look like you actually are fighting cancer, right? So it's a matter of like trying to establish balancing what are your goals as an individual, but also what are the symptoms and what can we control. Give you quality of life with whatever time you have. And some patients might have some, chemotherapy that can last long just to give them some quality of life and more time. Some patients might have, surgery to bypass the area or other strategies to kind of prevent that you have complications from the cancer itself, including a back or a stoma. Some patients, you might need to think about, well, it's necessary for palliation that we do something endoscopically, maybe placing a stent, so we prevent an obstruction and a potential complication like a perforation or so. So there are other strategies that we can use. They might not be the best, but again, we have to think about what is the life expectancy, what are your goals as an individual, and how can we help you to kind of like get a better quality of life out of this detrimental already diagnosis. With that, I'm going to just conclude over here. I have 2 QR codes. One of them is on the right side, over here in the middle, I guess. It's going to be for our anti-cancer challenge at UCI. So we have a race that is basically meant to help us to build funds for cancer care, not only for colon and rectal cancer, for every single cancer. And I invite all of you guys on Saturday, October the 5th in Aldrich Park, UCI, just to come over and be part of, even if you cannot run it or you cannot bike it, you can walk it, you can come with your family, you can come with the community, you can help us, be kind of like aware that this is happening. This is part of our community as long as the foundation is, and again, I'm gonna just be, subscribing to or, being part of membership of the foundation. But this is part of the community as well. It's a great event. I love it. I kind of like, make bets with every one of my coworkers and my fellows and everyone and see who's going to beat with. But the reality is the best strategy is we're beating cancer together. And that's the goal. The second QR code on the left side, correct, is our kind of like is the website that goes directly to the Center of Clinical Research at UCI Health. And there's a lot of information of what clinical trials we are undergoing right now, not only in colon and rectal cancer, but other type of cancer care. There's a lot of information there, or contacts, and how to just get more information if you're interested or one of your significant others is interested. So this is also part of what we have for the community, and feel free to just basically share it with your community and your significant others. And with that, I'm open to any questions that you have for me.
Thank you so much, Dr. Vilchez. Okay, so we'll come around and take your questions. Here we go.
Hi, I just have a simple question about presentation. Do colon cancer and rectal cancer present very differently?
That's a great question. Not really. It can be similar symptoms. It depends usually on where it's located and how advanced is the disease, The majority of them sometimes don't have significant symptoms. Sometimes you have bleeding or changes in your bowel habits. And remember, it's the same tube that gets connected. It's the same pipe that gets connected all the time. So people might have with similar symptoms with both of them. In more advanced disease, you can see other things like weight loss because your body's trying to fight and your cancer cells are eating basically the majority of your nutrients just to get fit themselves. So you might see some weight loss or some abdominal pain, some other symptoms that are more systemic. But yeah, it can just present in similar ways.
I know that your specialty is treating after you have this, and it has to be pretty significant for it to get to the surgeon. But is there anything that you want to tell us about prevention of this disease?
Yeah, that's a great question. I am kind of like in the realm of the curative, realm of healthcare. I agree with you. That being said, I do a lot of prevention because one of the things that I think is important to take into consideration is, one, diet, and everyone recommends maybe a Mediterranean diet. I always say I think you have to have a balanced diet. I never stop you to eat something in particular, but if you are prudent and you're balanced on what you do, it's really important. Try to avoid, of course, or we are facing a really epidemic of obesity, not only here but internationally, I would say, and obesity is also kind of like a high risk factor. The typical things that your doctor will tell you, don't smoke, get yourself active, right? Get a kind of like a balanced diet. Alcohol intake, it's kind of like a miss or hit in terms of like, well, can I just drink something or not? Again, it's imprudence, I wouldn't say you cannot drink and it's gonna just, prevent or kind of like cause the cancer, but definitely there are some cancers that are related to, really it's not colon and rectal cancer, but higher risk of other type of cancer. So I think a balance in general. I would say some things that we can use to prevent is, talk to your physicians. Express your concerns of like, hey, I am seeing this that is abnormal. Even if it's a change in your bowel habits, even if it's a change on, hey, I'm bleeding and I used not to bleed, or hey, my family got diagnosed at this age and no one has told me if I need to do a colonoscopy before, if I need to do any other testing. I didn't mention too much in the screening process or the self. There is not only the colonoscopy as a way to just, kind of like screen for colon cancer. We have some other tests that looks mainly for kind of blood, occult blood in the stools, and they are really good for the screening purposes, but it's not as good as a colonoscopy. Why? Two things in major. First of all, the colonoscopy serves as a therapeutic, meaning I can actually take care of things when I'm inside. I can take a polyp, I can take a biopsy, and it serves as the diagnosis, right? I can just see it, but I can also act on them. And people that have had positive, other tests like a FIT test or, a blood in the stool test in general, they most likely going to need a colonoscopy. The likelihood of finding a cancer is not as high. I will tell you, it's not like you have a FIT case and or a positive FIT and you have cancer, but you might have something like a polyp or so that might be, down the line could potentially prevent it or cause it, sorry.
Thank you. Next question. Here we go.
You didn't mention anything about genetic testing, and also can you comment on these less invasive forms of screening?
Yeah, 100%. Genetic testing is recommended for early onset colorectal cancer, meaning people that have colon cancer younger than 50 years old right now, because we have to make sure that this is not a component of it. There are multiple in the market. The reality is I always ask two things. One, you should see a genetic counselor, because that counselor can go through your history and kind of like tell you, okay, is there someone else in your family member that had a similar condition, one, or something that could be related to it, and how can we actually treat or screen the rest of your family if it's necessary, okay? The genetic testings are really good to just take a look abroad of what type of problems could be leading to this. Is there any type of changes in your genes that are, that you were born with that can tell me not only colon cancer, but can help kind of like as a map road to other type of cancers, okay? We do have a group of geneticists that are within UCI that work with us in that sense, and we actually have, a group of people that are trained on genetic counseling that can help us to just facilitate that in terms of like who gets a screen after or not. That is one of the things. The rest of the testing that we have for screening, which we have a good armamentum of them. As I mentioned before, the majority of them look for kind of occult blood. Some of them, the time frame, so two things, the specificity and the sensitivity, meaning that you're going to find something and it's going to be something that is actually meaningful, are less than the colonoscopy, one. Two, there might need to be done in certain amount of time. So if we're going to do a short scope, for example, I might need to do it more often, similar to what happens with the FIT test. And you have to do it more often to compare to the colonoscopy unless you have findings. And the second portion that I'll also mention is, as I mentioned before, I guess, is every time that you have something positive, I will always recommend you might need to have the colonoscopy because it's a strategy to see if there is something there. The reality of finding a cancer, and we were talking about these numbers the other day, might be 5% or so. Sometimes the majority of times what we find is a polyp. But that polyp can grow into other things, so it's better if you are aware that you have polyps and how long we can take. In terms of the colonoscopy strategy, some people might say, well, actually, we were having this conversation before. Some people might say, oh, I have my colonoscopy every 5 years, and that's it, And some other people, it's like, well, I have to get it every single year. Some people, it's like, it just depends on the risks that you have. So some people, as I mentioned before, they are kind of like forming more polyps and more, the strategy is we have to pick this up on time before they convert into something that is a malignancy or a cancer. So some people might need to just get more frequent colonoscopies, more frequent testing, just because of the risks that are higher. Similar to people that might have had history of cancer. Let's say, my brother has, 30 years old and got diagnosed. Most likely you might need to have a colonoscopy before that, depending on the risk factors, just check and make sure that you don't have, any problems, including not a cancer, but polyps or something that can just convert into it. The other thought that comes to me is time, right? We always talk about, okay, when I stop doing colonoscopies, and I don't think it's going on in the questions, but it comes along a lot within the community. It's like, when am I old enough to just stop doing colonoscopies? And, there is some data that would say there is not a lot of benefit if we start doing colonoscopies when you are 90 years old, unless you have, two things, significant risk factors, or two, your expectancy life is really high, because then you can develop something. So it's really individualized after the 80, basically, years old. I mean, that we say, do you need a colonoscopy or not? It just depends of like, do you present it with a cancer or not, and your life expectancy, and what are we gonna do for the treatment.
Thank you. More questions? Is that? Oh,
Since cancer cells require more nutrients than normal cells, what's your opinion about intermittent fasting decreasing the chance of cancer?
That's a great question. No significant data in terms of, I cannot tell you, hey, we proven this helps or not. Not to contrary neither. So it's kind of like in that, gray zone of like, does it make it better, does it make it worse? We don't have data that support either of them. I do think there are some benefits for some individuals. I do think that it's really specific as well. Like, it's like anything. I see intermittent fasting as any type of other diets. Some people are really, they get some benefit from it, and just because of your metabolism, some people might not do it. I have people that they cannot intermittent fasting because they're going to have, a really significant hypoglycemic, problem down the line. So all of these things are interesting, but there is no data to actually use background that it decrease the likelihood of having a cancer.
okay, maybe one more question. Do we have any more, or? Oh, well then, great. Thank you so much, Dr.
You're so welcome.
Vilchez. This
Thank you
has
so
been
much.
wonderful. As Jerry said, these are taped and they're available on our foundation website and our YouTube channel. And next month, our meeting is on April 22nd, and the subject is antibiotics, myths and reality. So we hope to see you here.